You can. Yeah, you can join. Already started.
To my mail. Registration approved.
Good afternoon, everyone. Trust when staying safe during this unprecedented and uncertain times world over. My name is Dr. Tobias. I work with the SafeCare team at Farm Access Foundation, and I'll be a moderator for this webinar today. I'd like to thank everybody for taking our time to join this webinar as part of Farm Access Foundation's contribution to the fight against COVID-19. We have been putting together a couple of webinars to educate colleagues, hospitals, and health systems on how to handle COVID-19. To take us through these presentations today, I have the Director of Research at Farm Access Foundation, Professor Tobias, and a Program Manager with the SafeCare team, Dr. Anire Asumah. Professor Tobias stimulates multidisciplinary operational research along the agenda of Farm Access with complementary inputs from Jolan's Institute. His research is mostly in areas of healthcare quality improvement, healthcare financing, diagnostics, and use of innovative mobile health technologies. Tobias also holds a chair as PhD and master's student of the novel coronavirus. Dr. Anire Asumah is a program manager with the SafeCare team, which is a quality arm at Farm Access Foundation. She is a public health decades experience working with development organizations. She's also a fellow of International Society of Quality in Healthcare, ISQA. She's a medical doctor by training and holds a master's in public health from the University of Manchester. She has a keen interest in health system strengthening and provides technical support to government and healthcare providers on resolving healthcare quality and patient safety challenges. So, Tobias, over to you.
Thank you very much. Maybe before we get started, thank you for the nice introduction. Some housekeeping statements here. Would you like to inform the audience?
Yes, thank you, Tobias. So we can always ask questions, ask our panelists questions during the short breaks. Please enter your questions in the Q&A panel. The moderator will pass the questions to the panelists and they will answer your questions in the Q&A breaks. We may have some connectivity issues as we have a lot of people joining on this at the moment, people from Netherlands and Nigeria, and due to the increase in use of online meeting tools, we may experience some connectivity issues. Please bear with us.
Okay, thank you very much indeed. Ms. Peggy, would you still like to make one or two statements, or can I just get started?
Please go ahead.
Thank you so much. Well, thanks everybody for participating in this webinar. My name is Tobias Rinke. I'm happy to present you some information on the virus. I'm by training originally an immunologist and virologist, and my goal is to give you a bit more of the biology of the virus and also a bit more on the epidemiology of the virus in my next presentation. I do hope you can hear me well. I see there are 78 participants at the moment. I do realize the internet connection might be not that good. I hope you can hear me, and I'll get started now. So basically, corona is caused by a virus. The coronavirus, COVID-19 is the name of the disease. And the virus is a quite simple organism. It is approximately 30 kilobases in size, which means it is 3 times bigger than HIV. And it is a very simple organism. It only consists of 6 proteins. And it has a kind of DNA, in this case RNA, as a genetic material. So it is extremely simple. And we see on the bottom of this slide a small graphic presentation of the genes of the virus. We're not going to go into the details, but it just illustrates there is 4 green genes, S, E, M, and E, and there's 2 orange genes, 1A and 1B. And that's it. The other small light blue blocks are regulatory small pieces of RNA. It is an extremely simple organism. And in that sense, it is quite strange that such a simple organism can create such a big problem. And I wanted to illustrate that in the next slides. So the virus basically is using its so-called spike proteins. You can see them in light gray on the outside to attach to the receptor for the virus. And the receptor for the virus is called ACE2. It's a receptor on the cells of the epithelia of the lungs, but ACE2 is also expressed in other parts of the body, for example, in the intestines, in the pancreas, in the liver. So the virus basically can infect quite some parts of the body, but in particular, it can infect the epithelial cells of the lungs. And after infection, the virus will go into the cell through a process of fusion, and then it will translate its material, and we're not going to go into the details, but eventually after going through the process, and it will use the cell to reassemble itself and to again move out of the cell, but then it has multiplied by a factor 1000. So there are 1000 times more viruses leaving the cell than originally entering the cell. It uses the cell to replicate itself, like any virus is doing. If we talk about the coronaviruses, there are basically 7 well-known coronaviruses in human beings. 4 of them are the so-called old coronaviruses, and 3 of them are the new coronaviruses. And the 4 old viruses are all zoonoses, and a zoonosis means a transmission of a virus from an animal to a human being. And those viruses have been transmitted probably a couple of 100 years ago. And those viruses are named with those different difficult names like 229E and NL63. This means the Netherlands, 63. This virus was found in the Netherlands, and so on. In other words, difficult names, but unknown viruses. They are already there for 100, maybe 200 years. They are harmless. They give light flu, nothing special, and they don't cause any big disease, and they are circulating around in the world. However, in the last 20 years, there have been 3 new outbreaks of coronaviruses, which are much more dangerous. And the first one was SARS in the year 2003. The second one was MERS in 2012. And the third one is in fact SARS-2, or SARS-CoV-2 as it is officially named. All 3 of those dangerous viruses are so-called beta viruses. There are alpha, beta, gamma, and delta viruses for corona. Doesn't matter so much. What is important is that in fact we're talking here about the 3 new zoonoses, the 3 new moments that the virus has moved from animals to human beings, which have caused important epidemics. Now, if you look at those viruses and their transmission, they will be transmitted through animals, and many of those animals are unknown. So for the SARS-2 virus, the one of today, it is at the moment not known exactly which animal it came from. Originally, it came from bats, but probably there is an host in between, which could be the pangolin, but we're not sure. SARS and MERS, we know they came from bats. SARS was transmitted earlier, and MERS was transmitted through camels. So there are different hosts that host those viruses and that make them move over. If we talk a little bit about the stability of the virus, that is interesting. This is detailed information, but basically what people have done is, how stable is the virus in air? How stable is the virus on a door handle, or on an elevator button, or on your table? And people did experiments where they cultured the viruses after a certain amount of time, and they see basically that the viruses are quite stable. In other words, the viruses can still infect tissues even after they stay for a long time on the surfaces of certain materials, like on plastics. The viruses can survive for 72 hours, on stainless steel for 48 hours, on copper or on cardboard for 8 hours. In other words, it is not known how much surface transmission or fomite contribution plays a role in the transmission of the virus, but it cannot be neglected. The most important way of transmitting the virus, of course, is through air and small droplets of sneezing, and by shaking hands with people who have touched their nose and touched their eyes. So the transmission is most normally done in that way. But there is also a contribution of the surfaces that we touch. So we should be careful. If we talk a little bit about the worldwide situation, I think a good dashboard is provided by Johns Hopkins. You can go to their website in their resource center for coronaviruses, and they keep track of the viruses every day. We see that we are now in the order of 2.5 million officially recorded infections. Of course, this is an underestimation because testing for COVID is not done systematically worldwide. It will be more, but this is the official figure. And we see also that at the moment, the epidemic is really very big in the United States and in Europe. It has left a bit China. It is decreasing there a little bit. I'll come back to that. And it's increasing in South America. And while we see Africa, the situation is still in an early phase. This dashboard is updated every couple of hours. This is a picture that illustrates a little bit better how the transmission of coronavirus takes place. It comes originally, as I said, from bats. And as we can see for the SARS virus in 2003, the palm civet cats were the ones that were in between, and then the transmission went to human beings, while for MERS, the virus went through camels and then to human beings. Human beings can infect other human beings by community contacts, or by nosocomial transmissions, which means transmissions in the hospital. And that can be done between, of course, nurses and patients, but also between patients and patients. And so there are different transmission routes known. And the 7 different viruses that I described to you, all of them have adapted themselves enough to human beings so that they can be transmitted by human beings to each other. The most likely, as I told you, in-between host for SARS-2, for the current epidemic, is the pangolin. You can see a picture of it here. And we see a nice picture here for the DNA people in our community, very interesting. For you, I just would like to summarize, is there are 2 important mutations that have taken place in SARS that play a role. And one of them is in the so-called receptor binding domain, which means for some reason, this virus has a very, very high affinity for its receptor, ECA2, which means it can stick very well to the cells, and it can easily infect those cells. That is a mutation as compared to MERS and SARS. And the other mutation is a so-called furin mutation, and that is on another part of the genome. And that mutation enhances the fusion of the virus with the cell, which increases again its infectivity. In other words, there are two big mutations that took place in SARS-2, in COVID SARS-2, that make it even more infectious than SARS-1, which took place almost 20 years ago. Well, if you combine this infectivity rate with the human behavior of traveling all over the world using airplanes, as you can see here, then you can imagine that spreading of the virus can easily take place. And if we go for that spreading, then of course we talk about the disease that follows after infection. And here we see a couple of slides first on studies done in China, because of course the virus in China took off the earliest already in December last year. And in China, the most important symptoms reported basically were fever in approximately 80% of the cases, cough in approximately 50 to 60% of the cases, myalgia in 25%, headaches and diarrhea in 10% of the cases. Those symptoms can be a bit different per continent, per country, and so on. And we see a more complete summary of symptoms in the next slide, which shows you that there is a longer list of symptoms, including sore throats, loss of taste, loss of smell, headaches, and sometimes also confusion. So it is a pretty long list of symptoms that all of them look a bit like flu and flu-like symptoms. On the right-hand part of the slide, we see a couple of strange things that are happening. You can see clear changes on chest X-rays. You can see clear changes in blood, in white blood cell counts, and in lymphocytes and platelet counts that go down, and in CRP counts that go up. And also in diagnostics, we can see viruses through PCR, and we can see antibodies through ELISA. I'll come back to that. If we look at how the timing of those different symptoms, here is a nice follow-up study that was done. It's in the New England Journal, and it shows basically. Can you still hear me? Yes. And you can see that fever is one of the very first symptoms, and cough. And then you see that other symptoms are coming up later. So fever and cough early, and then after a couple of days, there is nausea and vomiting. Diarrhea comes a bit later, and very late is also rhinorrhea. So symptoms can follow up each other, and that can be also quite patient dependent. So there is a development of symptoms in the first phase of the disease. If we look at seroconversion, we know seroconversion for HIV. Here we're looking at seroconversion for SARS-CoV-2. Then we can say quite safely that within 3 weeks after the first symptoms of SARS-2, almost 100% of the patients who are infected with symptoms will have seroconverted. In other words, have developed antibodies. The question is whether the person has developed enough antibodies and whether those antibodies are of the right quality to actually also confer immunity to the patient. Studies are ongoing. That's not completely clear. It looks like now that, in fact, the antibody responses are not that strong to COVID. And we see a lot of people with relatively asymptomatic infections having relatively weak antibody responses. In other words, whether those responses are protective or not, we don't know exactly. So the whole terms of herd immunity, group immunity, I'll come back to it, there are some question marks. But importantly, as you can see here, is that immune responses, both IgM and IgG, are coming up at the same pace and at a relatively quickly 2 to 2.5, 3 weeks after the first clinical symptoms. The next slide shows you a bit that, in fact, COVID-19 is a disease in stages. In other words, it starts as a viral disease and it ends as a host inflammation disease. In other words, at the start of infection, viruses play the most important role, and they will give damage because viruses will destroy the cells of the inner sides of the lungs, the alveoli. But later on, the immune system will become more important because the host will develop a big immune response against the viruses. And that immune response is somehow dysregulated. And that means that the immune response will get out of control and it will start to have an overactivity. And that overactivity has two important characteristics. One is the so-called cytokine storm. In other words, the immune system will produce a lot of so-called cytokines, which are immune molecules. And if there are too many of those molecules, they will start destroying your tissues. They will give damage to your pancreas, to your liver, to other organs. And secondly, your cytotoxic T cells, your soldier T cells of your immune system, they might start to overreact and they will start not only destroying infected cells, but also healthy uninfected cells in your lungs. So you will get additional damage in your lungs because of your own immune system reaction. So in other words, the second phase of the disease is mostly a self-response of the immune system and not so much damage caused by the virus. This is very important because it has consequences for the treatment of the disease, which means that probably in the early stage of the disease, we should use antiretroviral drugs, drugs that work against viruses. But in the later stage of the disease, we probably need drugs that suppress the immune system. And the timing and the administration of those drugs will become crucial for the future. If we look at fatality rates, then we see that the COVID disease in general is not that fatal at all in the younger age groups and only starts to become a bit important after the age of, let's say, 60. And we can see that fatality rates are almost 0% up to 50 years. They're 1.2, 1.5% in the age group 50 to 59. They're 5% in the age group 60 to 69, and they go up when you get older, up to almost 25% fatality rates in people who are 80 years and older. If we look a bit at statistics in the world, and we don't have to go into the details because you can see them all on the Johns Hopkins sites, but basically if we look at the top 10 countries at the moment, by April 19, 2 days ago, then obviously and very clearly the number one is the United States in terms of cases, almost 800,000 cases now. And we see Europe being number two. China was early, as you can see, but it's now stabilizing and in fact almost decreasing. If we look a little bit at the top 10 countries in terms of COVID cases per 100,000 people in the population, so that's much more a relative measure, then obviously the United States is not any longer number one, but Spain is number one in terms of numbers of cases per 100,000 people in the population. And you can see that other countries are also pretty high up, like Italy, as you can see on this slide, and also Belgium. If we look at the death rates in the world, then the death rates in the United States are obviously the highest. They are in the order of 40,000 at the moment. And number two is Italy, in the order of 22,000 people at the stage. If we want to fight the epidemic, there have to be done a lot of things. And the next talk will be about protection, so I'm going to skip this one, but obviously there are ways to avoid getting infected, and the next speaker will talk about that more. What also can be done, of course, in terms of epidemiology is so-called contact tracing. In other words, trying to find the contacts of somebody who has been infected by the virus and find out whether the contact person is infected as well. Here's a nice paper, again, in the New England Journal, showing the index patient, which means the first patient who got infected. He apparently visited Germany, and then patients 1, 2, 3, and 4 were meeting with this index patient during business meetings, and then you see that patient 1 develops symptoms and becomes positive for COVID after a couple of weeks in January 27. Patient number 2 gets positive a bit later, patient 3, patient 4, and so on. In other words, you can really follow the spread of the virus patient by patient if you do proper contact tracing. However, this is a very tedious exercise. You need to interview people, get to know who is meeting who, and we don't have time for this because the epidemic is evolving very fast. So therefore, there are new ways of doing this, which can be done digital using mobile phones. And a very important paper was published on this in Science, which I really advise you to read. This PowerPoint presentation will be available to all of you, so you can track it back. This science paper will tell you things that you can also see on slides here. It's basically using mobile phone apps to identify people with symptoms that look like COVID. Here you see an application of such an app in the United Kingdom, and within 8 days' time, there were 1.8 million people using this app. And we can see then that the spreading geographically of the users of the app, any people that report symptoms, people with complex symptoms, people who received testing for COVID, people who were COVID positive, people who were COVID negative. This is very crucial and timely information for policymakers to make decisions on targeting their money. Where should we intervene? Where are the hotspots? What can we do? A little bit on where are we with drugs, therapeutics. Well, I can tell you there are more than 500 clinical trials ongoing at the moment. And as I told you before, there are two classes of potential drugs. One of them are the ones fighting the virus, the antivirals, for the first stage of the disease. And the second class of drugs are the so-called immune modulators to fight the immune response of the disease. Well, what we try to do now in order to save time is to recycle existing drugs. So there's a lot of clinical trials ongoing with existing drugs. Like HIV drugs, lopinavir, ritonavir, which is a HIV drug, is being tested now for corona activities. Hydroxychloroquine, which is a malaria drug, is tested. Remdesivir is tested, which is an Ebola drug. Favipiravir for influenza is being tested. Ivermectin for parasites. So these are all drugs that have been used already, that are not that expensive, that are safe to use in human beings because we know they have already been used for other diseases, and at least they show some activity against COVID-19 viruses. So these are being tested at the moment. The other group of drugs that are being tested are the so-called immune modulators. These are mostly new drugs, and I'll come back to that maybe when you ask questions. Just 2 or 3 slides on Africa and then I'm done because it's almost time. Basically, there is, of course, also a screen for Africa. And here is the screen of the 15th of April, a couple of days back, when still we were below 11,000 infections. I think today we're in the order of 13 or 14,000. You can see the different hotspots of COVID reported cases. Of course, we have to be very careful here because there is very little testing going on and confirmation in Africa. So we might have underestimations. We might be in a very early stage of the epidemic, but there could also be other things playing a role, and I'll come back to that in a second. For sure, there are a lot of social and challenges for the COVID epidemic in Africa related to overcrowded clinics, overcrowded public transport, the necessity of people to go to markets, lockdowns, and will have very severe consequences. They are being done in many places. It will be difficult to adhere to it. So it is a real serious challenge. Another thing that's specific for Africa is the demographics. We see on the left-hand part of this slide the typical demographics for Africa. And we see on the right-hand slide demographics for the Netherlands, for my country. And you can see that the Africans basically are much, much younger than the people in my country, the Netherlands. And as we know, COVID is hardly playing a role with young people. So more than half of the African population is younger than 18. And people younger than 18 hardly ever have any COVID symptoms. So it could also be because of age distribution that Africa will have a less severe epidemic. Less and less people are older than 65 years, approximately 6% only above, below the equator. So the demographics are important. And that could mean that the spectrum of the disease might be different. In Europe, we see a spectrum like this, where approximately 40% of the patients are asymptomatic, 40% have very mild symptoms, 15% have severe symptoms, and 5% of the people die. In Africa, of the people with who are positively diagnosed. In Africa, that could be different. That pyramid could shift because of the reasons I gave before. The goal, of course, is, as we said in Europe, to flatten the curve. That is maybe something that should be achievable in Africa, but I'm not sure whether that's really realistic. Flattening the curve basically means try to take measures to avoid hospitals getting overcrowded. In other words, we have to avoid that we get big peaks like they're shown in this picture in red. We should remain below the dotted line in terms of numbers of patients over time. This is my last slide. It just shows you that maybe COVID-19 itself is not the most, not the biggest problem, but it could be also the human reaction to COVID and the way we deal with the epidemic that causes a lot of additional problems. We can make the parallel with Ebola, when the Ebola outbreak was in West Africa in 2015, 14, 2016. We see that, for example, the effect of Ebola on antenatal care was quite big. A lot of women did not show up any longer in clinics, and a lot of women did not get proper antenatal care. And that resulted in a lot of stillbirth. And that was really an issue. We also see that malaria cases went up pretty big time in Guinea. And there were many more excess malaria deaths also reported. In other words, the fear of SARS-CoV-2, of COVID-19, can already create a lot of havoc in the healthcare system in Africa. And we should take care that we keep having an eye for those who are not infected with COVID, and not only those ones who are infected. Thank you very much, and I would like to give the floor back to the organizers.
Thank you, Tobias, and apologies everyone for coming in late. I was knocked off by the net. And it says, can this app be applicable in Nigeria? How does it get implemented? People must have phones that could download the app, etc. And this person hopes that people will be sincere in their answers. Tobias?
We're talking about apps and the usage of apps to identify people at risk. That's one group of apps. There are also apps to monitor people who are already infected. And there are even also apps for contact tracing, which means they can give information on whether you have been in contact with other COVID-infected people within 1.5 meter distance, yes or no. These apps are under development in many places. There are big questions, of course, related to privacy issues. In my country, there is a big debate ongoing at the moment. My government tries to move towards apps, but there are also, and they made very proactive steps there, but there are big questions also asked in terms of personal privacy issues. I do think that digital apps definitely can play a big role because they're fast and they can reach many, many people, but it is important that everybody participates and not just 10% of the population.
Right. I think for me, it's in line with this app. I think for me is something I was thinking about, this kind of app being developed, especially in our environment where a few people tend to stigmatize for things like this. We had an example would be the hospital where the first Ebola case was managed. It took that institution a while to, hopefully they have even bounced back from that. They just are known as the Ebola hospital. So for me, it's a thing of, if there are apps who can tell people or let people know when you're coming close to someone who is infected, how do these people manage with the stigma? How do they, just considering how people could run away from people like that, even if they have tested negative, or how do we even navigate this, us as Nigerians, or those of us in Africa, how do we even use this? Is this something, I think this is where the angle, the question the person was asking, I think was heading. Is this something from your end? Is there any advice or anything you think we can do in these regards?
Well, concerning the usage of apps, we have to realize that the number of cases in Nigeria are still very low. You are a country of almost 200 million people, and there are approximately 500 cases reported. So we are in an early phase. I think the usage of an app that can help identify people with potential symptoms and do a triage and basically console a lot of people by making clear to them that they don't have any COVID symptoms and they just manage the fear of people with those symptoms would be very good. In an early stage of an epidemic, it is good to have an app that can help triaging people and send only those people with real serious symptoms to clinics and hospitals, symptoms that really are COVID related. And apps can play a big role in releasing the pressure on hospitals and hospital staff and on clinic staff at this stage of the epidemic. I would not go for contact tracing apps at all at this stage because that is in a much later phase of an epidemic.
Right, thank you.
That's my personal opinion.
Another question. Okay, thank you, Tobias. So there's another question, and this question is, you mentioned ACE2 receptors in lungs, liver, pancreas. How about kidneys and heart? Do we also know if there's a long-term consequence on the body even after testing negative?
That's a good question. The ACE2 receptor expression is not completely documented in all human tissues. It is clearly a receptor that is present in many organs. So you can indeed predict that the virus will create also organ damage. We know we can find the virus back in stool. It is not completely sure whether stool can also again infect people. So there is a infection route, an additional infection route here. Definitely the virus, at least from a receptor point of view, can attack other parts of the body than only the lungs and create damage there, yes. But the most important damage, of course, is created by the immune system that overreacts to the virus and causes the symptoms that make people have to go to the intensive care in hospitals.
All right. So here we have another question. In early stage of the infection, can full blood count tests be used to detect it? Looking at lymphocyte counts, is that a possibility?
Okay, the question about lymphocyte counts. Unfortunately, lymphocyte counts are too aspecific to be sure about infection. So I would not recommend that as an early marker. The only way to really identify the virus is through a PCR, which is expensive, unfortunately. That is usually the best way of doing it. We do have also antibody tests to measure antibodies, but these can only be used, let's say, 2 weeks after clinical symptoms because of seroconversion. I've shown you that picture. And antibody tests, rapid antibody tests are being produced at the moment in many, many different companies in the world. And they are currently being evaluated so that we can get a top 5 of best possible tests to be used. We have to be careful here because there will be a lot of rapid diagnostic tests marketed through all kinds of unknown channels that are of very mediocre quality. The best way of checking this is on the website of FIND in Geneva, and I can give you the links to that website after the talk.
All right, thank you. So I think we'll take maybe 2 more questions so that we can move on to the other speaker. For participants, please keep your questions coming in. We would respond to you directly if we're unable to take them. So there's a question here about, do you think we expect African countries to move into a mass testing strategy like South Africa?
Okay, the question about mass testing,
Yes.
I think is at this stage not needed and also not necessary, and it will be also very, very difficult to realize. Also in my own country, there is no mass testing. It is important to do testing on maybe on certain risk groups or on subpopulations. What you could consider is to do testing on blood bank donors, for example, because blood bank donors are quite a representative sample of populations. And that could give you an idea about immunity in the group, about herd immunity. That could be a possibility to do consecutive blood bank testing in capital cities in Africa, but I would not go for a complete population test. That is not feasible and also not necessary, because you will find 99.9% of the people negative.
Okay, so one last question. South Korea and China have reported a few positive cases after 2 negative test results. Do you have any explanation from a molecular biology perspective as to why this is?
Come again, can you repeat the question? Sorry, I didn't hear it properly.
Okay, South Korea and China have reported a few positive cases after 2 negative test results. Do you have any explanation from a molecular biology perspective as to why this is?
Okay, this is about positive results after negative results. I guess
Yes,
this
please.
was on PCR. You know, it is for every infection, you need, of course, viruses to replicate. And some people will have higher viral loads than other people. And some people will have viral loads that take some more time to build up than other people. So seroconversion or viral or conversion of virus infections will be different per person. On the average, people will have detectable viruses approximately 6-7 days after infection. But some people might have it only after 20 days. There's always a range that depends on your immune system. It depends on with how many viruses you were infected. It depends on your genetic background. So yeah, there are always some exceptions, but on the average, it takes a week to get positive viruses in the nasopharyngeal area of the human being.
All right, thank you, Tobias. So we have a lot more questions coming in, but for time's sake, we're going to move on to the other speakers. So my apologies to all those who have asked questions. We would ever respond to you privately, like I mentioned earlier. So thank you, Tobias, for your presentation.
You're welcome.
I would let Dr. Asumah take over from here. Dr. Asumah, over to you.
Okay, thank you, Peggy. Thank you, Tobias. Good afternoon, everybody. Tobias has talked about the immunology, the virology, and the epidemiology of COVID-19. So I'm just here to take us through some steps to help us check the readiness of our health facilities to handle COVID-19. If we look at the figures we have, as of yesterday, last night, the total number of confirmed cases in Nigeria was 665. And we know that Lagos is the epicenter. It's accounting for more than 50% of these numbers, even in the number of deaths that we see. In the next slide, we can see that if we look at the number of new cases weekly, we'll see that there is a spike in the number of cases in the 7th week. And that spike in Lagos, well, had a reflection on the total numbers of the country. We don't know why this is, but we know that in Lagos, some interventions were introduced. So in the 7th week, that was when they started the active case surge in the communities. And they've also now introduced decentralizing the testing center. So in every local government, you have at least one testing center, meaning that, next slide please, we're gonna have more tests coming up. Right now, we're seeing a steady increase. If you look at the cumulative numbers, we're seeing a steady increase in the number of cases. But with the new interventions being introduced, we're likely to have an increased number of cases. It is sure that we have not peaked, because when we peak, we'll then see the number of cases reducing. That just tells us that we're going to have more cases coming through our doors, and we must make sure we're able to identify them when they come. Next, please. So in Nigeria, I think we have a number of deaths, and most of those deaths occurred in the private hospitals. In most cases, the diagnosis wasn't made until after their condition deteriorated, even to the extent of death. And then we're now wondering, is it that we missed the diagnosis in the first instance? That is the likely thing. We missed the diagnosis in the first instance. It means that we now have to have a high index of suspicion. Whenever people come to our hospital, at the beginning when COVID started, cough, dry cough, and a high fever. That was the beginning. But we've gone past that now. We see people presenting with diarrhea. We see people presenting with loss of smell, loss of taste. So apparently these symptoms aren't classical, or we haven't been able to pin it down to a certain group of symptoms. It means we have to have a high index of suspicion. We may have set up screening centers as our facilities for COVID, but we must take a detailed history even when the patients come to us. Please go back. We must take a detailed history even when the patients come to us. We must make sure that we check them, we probe further for symptoms, we ask about everything. Whatever symptoms we hear, we must think about it as, okay, it could be, if someone is presenting with diarrhea, it could be gastroenteritis, but it could be COVID. So that index of suspicion is very, very important. What we see now in Lagos is that some hospitals have shut down because they have had cases, some private hospitals have had cases come through them, and they've had to shut down to decontaminate. The ripple effect of that is that we do not have enough hospitals for people that are genuinely sick to go to. We have reduced the human resource, as it were. So we must make sure that we pick up diagnosis as soon as possible. Next, please. As healthcare workers, we do not have a choice in this battle. We are in the forefront, whether we like it or not. We're not like other sectors when we can decide to sit at home and watch things unfold. We are in the battle, and because we're in this battle, we must make sure that we have the technical know-how and the resources to identify cases and suspect them and make sure we move them to good care, good quality care at the centers that have been recognized as isolation centers or designated as isolation centers. It is our duty to make sure that our staff are protected from getting this infection, and also our patients, because patients come for different reasons. Whilst fever, cough, and some of all those symptoms may be related to COVID, it may be related to something else, and you do not want the patients that come for other conditions to come down with COVID-19. We have our own role to play in flattening the curve, and what is that role? We must contain the spread. When we say contain the spread, we're saying we must promptly identify the patients, we must safely separate them, and quickly transfer them if we do not have the facilities to manage, or if we have the facilities to manage, initiate care immediately. Next, please. To help us prepare, SafeCare has a number of resources. So we have webinars that we're always doing. We're training healthcare workers, giving updates on COVID-19, some things to look out for. Please follow our social media handles. There's always one training or the other every week. We also have this checklist that we're going to, because if we're going to check the level of our preparedness, we must use something. There's something we're judging against, right? So we have this checklist, 2 checklists, which I'll be talking about later, and guidelines to help us use this checklist. We also have instructional posters for patients, for health workers, telling them what to do, how to protect themselves when they come to the hospital and whilst they're working. And we have all sorts of job aids, a triage flow chart, how to don and doff your PPEs, what kind of PPEs you need to use at each point in time. All these resources are available. Next, please. So when we talk about the checklists, 2 of them, they are to help us measure our level of preparedness to handle COVID-19. We're not saying that this checklist, it tells us what the problems are, where we have loopholes, where we have gaps. So we can prioritize those gaps, focus on those gaps, and bridge them to give us better outcomes. The 2 checklists cover the same components, but look at our preparedness from 2 different angles. So we have the health system preparedness checklist that is a quick tool, a rapid tool. It is usually used by management because it's assessing overall facility-wide what IPC measures are in place, what policies and trainings and supplies do we have to handle COVID-19. The health facility preparedness checklist, on the other hand, is a more detailed tool. And that is used by the quality managers, those that are handling or leading infection prevention and control teams. And then it looks at the requirements, equipment requirements, documentation requirements, IEC requirements, all through the facility. Next, please. Next slide, please. So what are some of the components that, no, go back one slide. What are some of the components that are covered by this checklist? It's looking at IPC measures. When we say IPC measures, the things that quickly come to mind are hand washing facilities. We think about waste management. We think about PPEs. We think about cleaning, environmental cleaning. We think about sterilization of equipment that we use. So do we have these measures available? Do we have policies to guide people? Because it's one thing to have whatever materials you require and measures in place. It's another thing for people to know how to use those things. Have we trained healthcare personnel on IPC measures? Remember that healthcare personnel, we have different kind of health workers in the hospital. So you need to give each cadre of healthcare staff the kind of information, just enough information for them to be able to perform their role in handling this COVID-19 pandemic. What is our triaging process like? The checklist also looks at our triaging process. How are we able to quickly identify patients and separate them whilst we check whether they are confirmed positive or negative to COVID-19? How do we, what's that process? Are we having a facility or a holding area within our facility where we can keep patients, or do we want to refer them? If we're referring them, what is that transport mechanism and communication mechanism with the NCDC or with the state governments? What is that mechanism like? Do we have the necessary materials? If we're holding them, what do we have to handle the COVID-19 cases? Do we have sufficient PPEs? Because at this point in time, if we're handling COVID-19 cases, then we're talking about the Hamzat suit and PPEs in that category and respirators. So do we have enough PPEs? Do we have enough equipment? Do we have enough manpower to handle these patients? We're also looking at limiting the movement of patients, especially when they have been confirmed or suspected to have COVID. Are we bringing all the things they require to them so that they are staying in that holding area or staying in that isolation ward without having to mix with people until they're discharged? What is that process like? Do we have all the things that are needed in those spaces? Hand hygiene materials, do we have them in place? So when we talk hand hygiene, we're talking about running water, we're talking about soap to wash our hands, liquid soap. We're talking about a means of drying our hands and making sure that we keep our hands clean at all times. How is our environmental cleaning? Are we just cleaning the floor and happy cleaning the floor? Are we taking it a notch higher to now clean surfaces, clean our light switches, clean our doorknobs or handles? Those are the things, because infection is easily passed through all those, is easily deposited in all those areas. And then how are we monitoring our health workers? Remember that whether they like it or not, they will have to treat this patient. It means that we're increasing their risk and exposing them to COVID-19. Are we monitoring them? Are we checking if they develop symptoms, if they didn't have symptoms at all? Are we checking if they're developing a fever? Are we checking, all these things to make sure that they are fine? And even after we've checked, what is our process? Are we then separating them and telling them to stay off work for a bit until, the time period has elapsed? And then what measures are we taking to reduce the number of visitors that come to the facility? Because like it or not, the more people we have, the easier it is to transfer infection to this. So these are some of the components that the checklist looks at. I'd like to take us in the next slide, take us through the patient's journey as they come from the gate and exit our health facility. So we have patients coming through our gates, and a lot of times we need to then train our security men to know what to look for at the gate. Some people know that once they come into the hospital, they're going to be asked about cough, whether they like it or not. Some are actually coughing and would want to hide their symptoms. So at the gates, they want to cough every cough that they feel they will need to cough whilst in hospital before they go in. So our security men should know that, you know, if they see anybody like that doing that, they should have a way of communicating with those on the inside to let them know that, okay, there's someone, he just coughed outside. In case you ask him and he doesn't give you any history about cough, please probe further. You know, they should know all these things. They should know how to check temperatures. Sometimes you see security 33, and then they just tell you to go without even, you know, they don't know that, they don't understand what the range should be. That could have been a thermometer malfunction. So they need to be well trained. If you're going to give them any role, then they need to be well trained to perform that role. So once they go to the gate, their fever is checked, they wash their hands before coming in, then they are directed to the pre-triage area, which is the area designated for screening for COVID. So in that area, you have people set it up differently, but they set it up close to the gate, you know, within the premises, but close to the gate, outside the main facility. So they have questions they ask about fever, cough. We will need to update our checklist because COVID changes every day. So whatever screening tool we're using at the pre-triage area needs to be updated. So if patients, you know, do not have any of those symptoms or they pass the screening, then they go to the reception and continue their journey through the hospital. But if they have, if they do not meet all the criteria, then they are separated and taken to the isolation area or the holding area where you keep suspects. Even when our patients go through, because we're now finding that there are a number of missed cases. So even when our patients have gone through screening and we feel like, yes, they can go into the main hospital now because we've not ascertained any risk, we should still do a triage. And at consultation, we should make sure we try and ask questions, take a detailed history as much as possible to know whether they still need to be separated or not. So from the separation area, we call NCDC or contact if we're facilities that are able to handle, that have been authorized to handle the patient. Then we conduct the tests, and then if they're confirmed, we move them to the isolation ward. If we don't have an isolation ward, then we contact NCDC, who then, you know, or the state government, who then takes it up from there and continue. So the idea is once they are done, it's either hope they haven't been critical. So the hope is that they recover and then they exit the facility. So at each of these points, we then need to make sure that these points can easily be identified by patients and by staff. We have posters, instructional posters telling people what to do. Please wear a nose mask if you're a patient, if you're coughing. As a matter of fact, today in Nigeria, I think they've encourage everyone to use a nose mask because or not. Do you have enough PPEs? Are they available? Your hand washing facilities, do you have adequate hand washing facilities? Have you trained staff? What is your ventilation like? What is the spacing in the waiting area like? What is the illumination like? You know, what equipment do you have? So we're checking for all these things in all the different areas of the facility. And then when you check, you then know if indeed you're ready to handle COVID-19 or not. And if you're not, then you can ramp up your readiness. Next slide, please. Next slide, please. So as healthcare workers, we need to make sure that we have basic information so that we can send the right message out to our staff and send the right message out to our patients. There's a lot of information out there. Sometimes it's difficult to sift between truth and fiction or myth and what is correct. So we must get the right information and send that information to our patients and staff. We need to stay informed. Remember, COVID is new. It's never been experienced before. So there are surveys, there are researches going on every day. Things are being updated. You know, there's a lot of updates going on. So we need to stay informed. And as we're getting updated, we need to update our patients and staff as well. We need to train, and train. We must pick cases when they come through our facilities. We must suspect them. Otherwise, we're going to spread infection. So imagine, and on IPC, what measures do we need to prevent and control infection? When we identify patients that are sick or that are suspected to have COVID, we need to separate them and fast track them. We must use our PPEs. We must use our PPEs, and we must use our PPEs correctly. Sometimes you see doctors or healthcare workers putting their face masks on their chins and then pulling it up to their noses again. That is wrong. That is going to infection spread things have been deposited there. So we must use our PPEs, and in this period, we must use PPEs. So we don't have to wait for our PPEs to finish. We must make sure we're monitoring our stock. And then, you know, asking for a top-up of PPEs when we need them. And if we have run, because I know that there's a general shortage of PPEs now, then we have to think of ways to get PPEs, to make some of them and make them available to our health workers to use. Next, please. So now we know that we talk about slowing the spread, we talk about flattening the curve. Flattening the curve doesn't mean there will be no infection or there will be no cases. We're just trying to slow it down so that we build up our capacity as in the health system to handle the cases. We have some national measures in place which have been mentioned, which, you know, we keep talking about and there's awareness about. But a lot of times we see that these national measures are somehow tilted to the community. So we must realize as healthcare workers that these measures apply to us, and we must think of how we can, you know, implement them in our settings. So when we talk about hand washing and improved hygiene, that's one of the measures. We must have hand washing facilities in all areas of the facility, everywhere in the facility. And it's not just having those hand washing stations. We must have running water there. We must have soap. We must have a way to dry our hands. We must have a bin to collect the dirt. We must observe the moments at the 5 moments for hand hygiene, because it is very important. You don't want to transfer infection to another person. You don't want to pick up any infection. You need to avoid touching your face as much as possible. You need to make sure that, like I said, wear your PPE. You must remember respiratory etiquette. It's not enough to tell our patients, you know, to cough in their tissues or cough in their elbows. We must also make sure that if I have a cough or want to sneeze, we do the right. We must. Sometimes we just, we leave our ward coats in the hospital and come back and meet the same ward coats the next day and just put it on. But we need to stop doing things like that because we need to improve our hygiene. We also need to clean and decontaminate surfaces. Cleaning the floor is not enough, but surfaces need to be cleaned. And we're talking about our desks, our tables, doorknobs, handles, light switches. We need to make sure we clean thoroughly. And what are we using to clean? We also need to consider the chemicals that we're using to clean. Next, please. And avoid touching light switches, door handles, because germs are usually deposited there and they're not areas we would typically clean. When we talk about social distancing, or like we like to say in Nigeria now, physical distancing, we must know that every patient, every individual is a suspect until proven otherwise, especially because there are asymptomatic cases. So they're not showing symptoms. They feel they're fine. They're not doing it intentionally, but they're spreading infection. So we must use a face mask. I think that's the directive now for everybody. It's been the directive for all healthcare workers to use a face mask. So we must use a face mask and encourage our patients and colleagues to use a face mask. Especially for high volume centers, we must reduce the crowd, because when you reduce the crowd, it's now easier to space, you know, people. It's easier to, your waiting rooms will now be freer. So we need to think of ways. Do we want to are running clinics and all they come to do is maybe get a drug refill? Do we want to send their drugs to them? Do we want to think of setting up a kiosk somewhere where they can just come and pick their drugs. At this time, we really shouldn't be handling elective surgeries. So any surgery that can be postponed, by all means, should be postponed until after the pandemic. Sometimes we can also do follow-up through phone calls. There are a lot of digital ways, to get to our patients. So we must think of ways to reduce the crowd that comes into the hospital. We also need to, everybody knows, we're not expected to have contact when we're greeting now. So there are different ways people can greet themselves. Just saying hello is just fine. And you need to keep it able to entirely achieve 2 meters within the hospital. But we must, think about how we do our consultations now. Give more distance between yourself and your patient during consultations, and use a face mask. Even when you're having meetings, that's not when to be sitting very close to your colleague. Give that distance. In waiting areas, let's space out the patient so that you're reducing the spread of infection. And I know that we're hospital workers. Sometimes we're given accommodation in the hospital. If we have that option, please stay in the hospital as much as you can. If you have to go home, you can stay in a separate house if our houses give that option. Otherwise, as we're getting in, we're going straight, to an area where we take off our clothes, take a bath before we can now mingle with the rest of our family. And please avoid the elevator. It may get us up faster, but we may pick up germs as we're going. If you're stuck in the elevator with someone else and the person decides to cough, you have nowhere to run to. The buttons on the elevator are also areas where germs are deposited. So please, please, please use the stairs. It's even healthier to use the stairs. Next, please. If you have, next, please. And then if you have patients that you suspect or that are confirmed to have COVID, if you are not authorized, please contact the NCDC, contact the state government. They have processes in place to come and do the test and to evacuate this patient from your center to the authorized isolation centers. You must have a screening area. You must have a holding area for everybody. You should have a screening area where you're screening for COVID, and you should have a holding area where you keep patients temporarily until the NCDC or the state government comes to pick those patients up. We need to improve our triage process. Update your triage checklist. Update, there are many checklists, there are many case definition checklists. You must make sure that you are following the NCDC and updating them so that they are relevant and you can pick up these cases. You must have a high index of suspicion. We do not want to miss these diagnoses, because the more we miss them, the more they go into the community to spread the infection. We must make use of our PPEs, and please monitor yourself, monitor your staff, report any exposures and report any symptoms. Next, please. Feel free to reach us at SafeCare, to contact us at any point in time. We are happy, very happy to work with you, to support you through this journey. Together, I believe we can fight COVID-19 and win the battle against the disease. Thank you.
All right, thank you, Dr. Asumah. If we could just go back one slide so that everyone can have the contact addresses. Yes, please, because I see a question about if people who are interested can get the checklist and other materials. Yes, please, just reach out to any of the email addresses or phone numbers that you find now on your screen. So I'll take 2 questions for you, Dr. Asumah, because of time, and also because, yes, please.
Okay, can I just add that the webinar is being recorded. So after the webinar, you'll get an email, and the link to all these resources will be in that email. So you know that you're going to get the resources if you need them.
All right, thank you so much. So I was saying I would just give you 2 questions because of time, and also because you had answered some of the questions I see here now during your presentation. So the first question is, patients and relatives have over time refused to give the information have refused to give correct or complete information. So that invariably affects history taking and therefore causes misdiagnosis. So how best can we manage this? This is what this person wants to know.
Okay, so it's true that patients sometimes hide their symptoms and hide information from us, but we need to probe as much as we can. And once we start seeing symptoms that may not necessarily go together, you know, it's just one symptom here and another one there, then just, I mean, like they say, it's better to err on the side of caution. So just treat the person as a suspect and then carry on from there.
Right, thank you. So here is another question, the last today. So where is that question now? 1 minute. Okay. So what measures are being put in place for those in remote areas? Are information available in different languages?
I know that the NCDC and the state governments have put out some information, some in pidgin language. I'm not sure about, you know, the common languages in Nigeria, but I believe that that is there. We have organizations, development partners, and different people interested in COVID and putting this information out there. So they're trying to, we know that information hasn't necessarily permeated the very rural areas, but there is a drive to get information to those places and putting it in a language that they can understand.
All right. Okay, so there are more questions coming in though, but we would unfortunately need to respond to these people directly via their email addresses because of time. I'd like to thank the speakers today for taking us through this webinar, for your time and your effort in ensuring that we understand the message you're trying to pass across to us. I'd also like to thank all the attendants for attending today and encourage us to check our social media handles, as we're always training and we always put information out there. For those who have asked questions that we could not respond to during this live webinar, we will respond to you via your email addresses. So thank you everyone for today, and we hope to converge again sometime soon to discuss on more issues as it concerns the pandemic. Please do stay safe and God bless you. Thank you.